we'll spend 25, maybe 30 minutes talking about acetaminophen toxicity. The good thing is there's not new information here. What I love about this talk, though, is the summary of all the concepts we should really know, how to apply the concepts, and how do we really apply this clinically. If we want to talk for 2 seconds, the simple thing is if they come in with suspected acetaminophen toxicity, just give NAC, and we're done. You can just give it, and we're set. But we'll talk about a little more detail to define some of the nuances of this, which I think are actually very interesting in this chapter. So if you look at APAP, and you take a look at how many preparations it's in, we really don't do a good job as physicians advising our patients, particularly when we prescribe agents that contain this, to let patients know, you got to limit your intake of this elsewhere. It's in so many other things, and patients don't get the difference between aspirin and acetaminophen. They just don't. You look at this first article, actually this was one just before that. If you look at the beginning of the chapter, American Journal of Emergency Medicine, and it's from 2003, they really commented there that emergency physicians are not great about educating patients about this. And I don't know if we think about it much. Anything that's released over the counter, I think we intuitively think, great, it must be safe also. Why in the world wouldn't naproxen be released as an NSAID over the counter? That's always amazed me. It's the number 2 or 3 NSAID associated with GI bleeds, but that's one they chose to throw over the counter. I'm amazed that they did that. But nonetheless, they did. Acetaminophen is very interesting as well. And we'll talk about the approach in the UK versus our lack of approach in the US regarding acetaminophen toxicity, and there are ways to help people. So what role does acetaminophen have in the development of acute liver failure in the US, and what steps can be taken to reduce the risks? We'll look at abstract number 1, retrospective chart review, 71 patients with acetaminophen toxicity. 50 were suicide attempts. Mean dose was 24 grams. Remember, we usually talk about 7 grams versus 150 milligram per kilo. This is a lot, 24 grams. And then there were 21 accidental overdoses for pain relief. The person with the toothache that was prescribed Vicodin at one hospital, Percocet at another, and they're also taking over-the-counter acetaminophen, and now they've been taking this for a while. Their mean dose was 11 grams. Who does worse? The chronic overdoses, the unintentional ones, or the ones who want to end their life that day and come in immediately? Even with a larger dose, the people who come in immediately tend to do a lot better. So 5 patients with a toxic level less than 4 grams in 24 hours were noted in this article as well. So what that tells us too is that you can even have even the very, very low dose of 4 grams per 24 hours, which has been noted to be very conservative. You can still have hepatic toxicity with that. So it's not a benign drug, it really isn't. Accidental overdoses, more likely to present longer to presentation, greater than 24 hours, and that's why they don't do as well. Significant lower mean peak levels. They had 39 versus 145 compared to the acute ingestions, but they had higher LFTs, no surprise there. Mortality rate, 19% for the chronic ones versus 2% for the acute ones. And APAP has been noted to be, or touted to be, the responsible for 40% of acute cases of hepatic failure. 40%. And I don't think we're considering that. When we're seeing patients in the emergency department, what do we do when we see increased LFTs and we do the gallbladder ultrasound, all that's okay? Hey, let's order the hepatitis screen. Hey, let's go back and ask them about APAP exposure and use. That's what we should be thinking about. The hepatitis screens and profiles frequently come back normal. We haven't considered the possibility of chronic overuse of supertherapeutic doses potentially, or even therapeutic doses of APAP, causing hepatic toxicity. And there's benefits still with NAC in those patients, so we're missing them. And if you look at the risk management issues with that, although this is a difficult diagnosis to make, this is great for the plaintiff's attorneys to hang on to, because particularly with the nomogram there, it can be easily said, well, you missed the opportunity to diagnose this in a reasonable time frame, you did not meet the standard of care, you didn't provide the antidote that is clearly available, and there's a damage here, and there's a bad outcome, you're responsible for it, and we need you to pay for it. It's not the right thing to do, but I tell you what, it's something that can definitely be a problem. We've seen it at least on a few cases. All right, abstract number 2. 1980s, they studied, it was based on transplant center data. They studied this, looked at the patients that were referred. 20% of cases of acute liver failure were secondary to APAP, but they didn't include some of the cases that weren't really referred for transplant themselves. So they said it's really as high as 40 to 50% of cases are secondary to APAP. When you include all those cases of hepatic failure that were referred to the center, but those initially when they said there's 20%, those were just the ones who were being referred for transplantation. All right, abstract number 3, change in occurrence of APAP overdose in the UK. This is very important. 1998, they recognized that there were some significant overdoses and significant problems with this drug. So they basically restricted the use, and it has worked great. They used blister packs only. You know, blister packs, the kind you have to pop open? And so it's not just a jar full of things. You can just open your mouth and say, well, acetaminophen is so simple, it's so easy, it's so safe, I'll just take a mouthful. Well, you're going to have to open up a blister pack, and they limit the amount that you can purchase over the counter to 16 500 milligram tablets. And the pharmacy packs that you could get from the pharmacy were 32 behind the counter. You needed a prescription if you were going to get more than 100 tablets. And did it work? It absolutely did. 1 year after, acetaminophen overdose decreased by 21%, and severe overdoses decreased by 64%. This worked in the United Kingdom. And as kind of a control, they looked at benzodiazepine overdoses. They stayed constant. So it's not like, well, all the overdoses decreased, so that's why it worked. No, this intervention worked. Why it isn't implemented elsewhere, I am surprised and don't understand why. And in the US, why the FDA hasn't picked up on this when we know this intervention has worked is really pretty sad. All right, well, a couple more pieces of information just about the drug. McNeil's the manufacturer, and they've recommended not to exceed more than 4 grams in 24 hours. Very, very conservative, although, as I mentioned, you can still have toxicity at that dose. And it's listed, too, with them that it is very unlikely to get toxicity even with 10 grams per day. If you get that amount, it's very unlikely you're going to get toxicity. Very unlikely, but it could still happen. So they've really lowered that dose substantially, so 4 grams per day shouldn't do it. 20% of cases of acute hepatic necrosis never has an etiology identified. So could those also be acetaminophen? Maybe. So we really need to push this to the front of our minds when we're seeing patients with increased LFTs. Abstract number 4. These were also looking at referrals to a liver unit, and after post-legislation with limiting the amount of acetaminophen that you could get your hands on, they had 2.5 patients per month decreased to 1 patient per month, and referrals to the National Transplant Registry decreased from 3.5 per month to 2 patients per month. So again, speaking to regulation of acetaminophen availability and how we distribute this. 137 cases in abstract 5 of acute or chronic APAP overdose at the University of Virginia E.D. It was over 4 years, and many could not be characterized at all by the nomogram, and this is a limitation. So many of these are chronic overdoses. We know the nomogram is good for one thing. You've had a one-time ingestion, and you know exactly when it was. Other than that, you really can't use it. So don't take a look at the nomogram, you order the level, and say, well, you've had 2 doses in a 28-hour period. Don't say you're falling below that possible toxicity line, or there's no chance you could be toxic. If you're having symptoms and you're worried, you just need to treat it. And that toxicity line, that thick line on the nomogram, is basically the 25% likelihood of developing this disease. So it's actually very, very conservative. All right, what else do we have from that abstract? They said a single overdose shortly after or shortly before ED presentation was about 84% of their patients, but only 18 of the 115 of those had any potentially toxic levels when they sampled them. They were maybe there just too early. A large single ingestion with presentation delayed for 18 hours, that was only 5% of their patients, and no APAP level were undetected in all cases. They had none of them. So again, patients who could be sick, the level didn't really help. 2 out of 7 of those cases, however, had elevated LFTs. One of them was a chronic alcoholic, and we'll talk about that. Does alcoholism really impact how we respond to acetaminophen? They're both metabolized in the liver. Maybe it does. Maybe it doesn't. There's some conflicting data. I'd say that the pendulum is swinging more toward chronic liver disease, really impacting how we metabolize this and making it more likely to be more toxic with this drug. But acute alcohol use actually doesn't. We'll talk about that in a little bit. All right, what are the characteristics of APAP overdose in the ED? Let's take a look at abstract 6. They looked at, interesting, a decision rule to limit the testing. Well, kind of an interesting abstract, but it's an easy test to get. It's not expensive, so why do we want to decide when we shouldn't order it? So I don't know why they decided to do that, but still there's some interesting information that came from it. They looked at 307 patients aged 16 or younger, and they said if you were English speaking, denied Tylenol exposure, denied previous overdose, denied drug abuse, no current alcohol use, and your Glasgow Coma Scale was 15, you didn't have to worry about it. You really probably didn't have to order the test. That was their hypothesis. APAP was denied by 50% of the patients, but 8% of them actually had levels. And this really speaks to what we know about overdose patients. If you really want to overdose yourself, how honest are you going to be with the provider who's trying to help you not do what you want to accomplish? You're really not going to be very honest there. So you have to be a little bit careful. And this abstract doesn't provide much beyond that to help us understand the psychology behind it. He said 85% would have required testing anyway per the rule. So they kind of showed why this rule was not that helpful. And so again, a rule telling us when not to use a test that can be vital and is not expensive and not hard to get, probably not that helpful for us at all. An early clue to serious overdose is persistent vomiting. Remember that. But that should also clue you into other overdoses. Theophylline, aspirin, iron, DIG. Think about all of those things when you have somebody presenting with vomiting alone. All right. In the setting of potential APAP toxicity, what tests should be done and when should they be performed? Let's look at the next several abstracts. Number 7, they looked at 1,000 patients, 1 to 5 years old, and basically the take-home message here is they used the elixir. Was it absorbed more quickly? Yeah, it probably was. This age is much less susceptible to toxicity. They recommended increasing the treatment level up to 225. Really, the nomogram says 150, and that's what the standard is, but most places really use 200 as a more reasonable place to start treatment. You can use either in that range. And consider a 2-hour level. What's interesting too, be careful because a 2-hour level will oftentimes be higher than the 4-hour level. So if you've ordered it too early, make sure you still get the 4-hour level and base your decisions, if it's an acute ingestion, a one-time ingestion, on the 4-hour level, not the 2-hour level. And particularly with kids with an elixir, I mean, they're going to absorb it quickly. The 2-hour level may be all you need, but there's that caveat, so be careful with that. All right, number 8, 249 patients, 12 years or older. They had repeated super therapeutic Tylenol ingestion, so over 4 grams per 24 hours, and they had that at least for 7 days, or at least for more than one day or so. Actually, the duration was 34 to 72 hours. So you would think, wow, this has been for a long time and they developed toxicity. When we think about chronic acetaminophen toxicity, we're thinking months worth. These patients were 34 to 72 hours, that's it. So it didn't take long for super therapeutic doses, and they weren't huge. Instead of taking 4 grams a day, maybe they were taking 6 grams a day. It wasn't necessarily a lot, but it created a problem. Interestingly enough, AST levels greater than 1,000 are reported in this article as evidence of hepatotoxicity from acetaminophen if that's what you're concerned about. And if the AST is greater than 1,000, you have to have a toxin on board. Other forms of hepatotoxicity aren't going to cause an AST greater than 1,000. And I think it's a great pearl and a great take-home point for you. In those cases, in this particular abstract, 60% of them had an AST of 50. Their level of APAP was 27. The dose they took was 10.6. Those who had an AST of 50 to 1,000, that was 22% of the patients, and the level was 19. The dose they took was 11.7, and greater than 1,000, 18%. The level was 34, so not even that high, and the dose they took was higher, of course, at 12.6. Be careful with your level. It's not always telling of who's sick and who isn't. And what else did they take a look at? NAC treatment. They decided to treat these people with N-acetylcysteine. And remember, these were the people who, you know, really, you didn't know for sure if they really had toxicity. You were just worried about it based on the history they provided. So 50% of them with an AST of less than 50 were treated. 2 had asymptomatic increases in APAP levels. The 50 to 1,000 group, 15% had hepatotoxicity and 1 death. And the greater than 1,000 AST group, 16% died or had a liver transplant. So follow the AST, that's important. I remember in the past, many years ago, it was, well, you know, I think it was the PT. If the PT is elevated, that's going to be a more sensitive indicator if they really have early hepatotoxicity. Well, now the focus is on the AST, and it's a good marker for this disease. One caveat here, too, is an increased bilirubin may falsely elevate the APAP levels, so be careful with that. I wouldn't discard the possibility of treatment, but, you know, consider that possibility. Abstract 9, 145 healthy adults, 18 to 45 years of age. They had acetaminophen with multiple other agents. Oxycodone, Dilaudid, morphine, other things were given with this. 4 grams per day times 2 weeks. That's all they had. ALTs increased 3 times to the upper limits of normal in 31 to 44%, and 5 times the upper limits of normal, 19%. But none of them got sick, and it went away. It continued to rise 2 days after they stopped taking the acetaminophen, but it went away, and what these authors said was, see, it's not a safe drug at all. Well, you have to be careful not to make that leap. Yes, it's going to elevate those levels, but it doesn't mean everyone with therapeutic doses, the overwhelming majority of those with therapeutic doses, even if their ASTs go up a little bit, they are not going to have a problem with developing toxicity. All right, number 10. APAP is detected in the urine within 30 minutes of a 1,000 milligram dose. So the question is, do we need to get levels? I don't know that this is ever going to get into mainstream practice, but I like the concept. If we can do a urine dip for APAP and it's negative, well, then maybe we don't need to know what the level is if it's just negative. Do we need to get a quantitative HCG when we know the urine HCG is negative? No, we don't. And maybe this can be applied in the same way. Abstract 11 talks about the nomogram not always being accurate. They really looked at 2 cases where it went above and below the nomogram levels, and you just never know what you want to do with this data. So they recommended sampling at least 2 to make sure you have 2 points to plot on the data curve with the nomogram, and make sure that it's not fluctuating above or below before you make a treatment decision. They had no firm timing suggestions, but they kind of implied that maybe 4 hours was the right time to do the next level after your first level. All right, does concomitant consumption of alcohol predispose to APAP toxicity? We touched on this a little bit ago. We'll talk about it with abstracts 12 and 13. Acute toxicity? No, it doesn't make things worse with APAP if you drink alcohol. Actually, it makes things better. And why is that? Anybody? Anybody who would be in the patient, or the registrants who are awake at this point. You guys are asleep. A lot of skiing today. But basically, if you have competitive inhibition, you're metabolizing that alcohol, then you can't metabolize these other things too, and it really helps the process. And so that makes things a little bit better. Chronic liver damage due to chronic alcoholism is a different situation, however. It's a greater risk. Some people have said it's due to glutathione deficiency. And glutathione is what really helps us as well to make sure that NADQI, NADPQI gets metabolized properly. And if you're glutathione deficient, maybe it can't get done. And that's not been proven, but it's one theory. And abstract 13, 533 patients admitted to a liver failure unit. Interesting here, there was no association with alcohol use or chronic alcohol liver disease and survival or hepatotoxicity from overdose with APAP. So they kind of refuted that even chronic liver disease didn't seem to have a correlation, but it's one study, 533 patients. And they did talk about, most physicians are pretty conservative with this subset of patients. If they have chronic liver disease, then most of us are going to say, let's treat them earlier and let's be a little safer. And I think that's a reasonable approach, although there's no literature to really support it. So they said a 4-hour level of 100, a lot of people would treat. It's arbitrary, but it's reasonable to do so. All right, what is the safest analgesic for patients with alcoholic liver disease? What do you think? Should we give them NSAIDs? Not a great idea. It causes GI bleeds. Also can cause some hepatotoxicity. You know, we do know that, that acetaminophen is metabolized not just through the liver, but where else? Kidney also. So we've got another pathway there too. Abstract 14 looked at what's the best agent, and this is a great question to ask because we have this all the time. The drunk person that needs something for pain, what are you going to give them? Well, still, based on all the information we have, despite the concerns about hepatotoxicity with chronic liver disease and acetaminophen exposure, acetaminophen is still the safest out there. 201 adults, they were entering a detox unit, and they gave them, for 2 days, 4 grams per day for whatever aches and pains they were having. They had normal baseline and post-treatment LFTs. Malnutrition was identified in a third of those patients. I'm surprised it wasn't higher. And that refutes the glutathione deficiency issue. So maybe that's not really an issue, and it's just a theory. Acetaminophen, they said, was safest. Again, NSAIDs are not a great idea, but what you have to reinforce with the alcoholic patients are short-term use of the drug and standard dosing. And I think we really have to emphasize that with all of our patients. What role does activated charcoal play in the treatment of APAP ingestion? Does it have a role? Not really. And what's great about our antidote is it's so good, do we really have to worry about gastric decontamination if we know that there are some questions with it? we don't have to worry about gastric decontamination. If you get somebody early on, or you have a multiple ingestion of a serious toxin, you need to jump in there and maybe do gastric decontamination if it's within an hour of that ingestion. But otherwise, if you know it's purely acetaminophen, just go to the N-acetylcysteine and you'll be fine. There's no proven benefit for charcoal for gastric decontamination with APAP exposures. And there's been some discussion that charcoal would decrease NAC as well if you do them both orally. Well, that's negligible. That was looked at. The amount that changes is not really that important. I mentioned that for historical purposes because now we have IV NAC, which is a lot better, a lot easier to use. All right, no NG tubes in peds and uncooperative patients. You know, if we really think we need to get charcoal in somebody and they're spitting it across the room or they're a little kid, it's not worth it. In acetaminophen overdose, we can use NAC to treat them with the antidote, so don't do it and cause a complication. They also stated in this group of abstracts as well that 10 grams or more within 4 hours, the levels above the possible risk line. If they had charcoal, 28%. If they didn't have charcoal, 41%. So it was one article, I believe it was abstract 18, that said maybe there is some benefit here, but we know too, we've got a great antidote, and if they're going to run the risk of causing a problem, aspiration, or an injury, trying to force some charcoal down somebody, I just wouldn't do it. Abstract 19 is interesting. How do they make this better and more palatable? Well, they said diet colas, caffeine-free cola did not impair absorption of APAP by charcoal. They were trying to make it taste better, and they were worried that some sort of soda was going to then impair the ability for the charcoal to absorb the APAP. Well, that doesn't happen. So if you're still giving, you're still giving charcoal and you're worried about that to make it more palatable, I wouldn't make the slurry. I mean, I think that's kind of part of what we're doing. All right, we're not going to use the Ewald tube. We're not going to teach you a lesson that way, but you are going to drink this stuff, remember this day. We're not going to make it taste better for you. All right, how about whole bowel irrigation? What do you guys think? It's a great science project for you in the ED. Is it going to, I mean, that's a scary thing. Get the bedside commode if you're going to engage in this practice. It's not a great thing. Yeah, the bathroom is 6 doors down on the right. You don't want that happening. You'll have housekeeping in there all the time. But is it really helpful? When should we use it? I don't think it's really great for this. Abstract 20, whole bowel irrigation is really reasonable for sustained released agents, whether it's APAP or something else, something that can develop concretions like the heavy metals, those type of things. You can do it with the body stuffers, but not the packers. Remember, the packers have things nicely packaged. And it has been discussed and reported that if you throw a lot of fluid in there, that you might actually open up some of those packages and bolus them with whatever agent they're trying to smuggle. But somebody who just stuffed a bunch in their mouth, yeah, you can use whole bowel irrigation for that. That's not a problem. With this abstract, too, they looked at 10 healthy subjects. This is amazing. I don't know how they got these people to do this and what they paid them. They used radiopaque markers just to see how well they would transit the bowel. And they gave them 75 milligram per kilogram sustained release acetaminophen tablets. And they did this whole bowel irrigation thing with Go Lightly with a feeding tube 30 minutes after instilling these things. And then they did it again. They got him to do it a second time. We weren't sure the results were right the first time. We want you to shake things up a little bit and see if things move through more quickly. It was pretty scary. There was an 8.1% reduction in maximum levels, but it was not statistically significant. It didn't impact anything. What they were excited about in this article is that it shifted the radiopaque markers around a little bit better. So they thought that there was better transit with those. So if you need to get something out of the colon quickly, maybe Go Lightly is the way to go. But are we going to impact acetaminophen levels with this? No, we're not. What are the advantages and disadvantages of IV versus oral NAC therapy? Anyone using this orally anymore? Maybe some small advantages. One of them is a first pass effect. You take it orally and you ingest it, you're going to get the first pass effect through the liver, which is hypothetical, but maybe you'll get a little earlier effect. But has anyone ever smelled this stuff? Oh, it's pretty nasty. It's pretty bad. So there's one benefit there to give it IV. IV is not associated with nausea and vomiting. The protocol is 20 hours versus the recommended 72 hours. IV has a slight risk for hypersensitivity reaction, but you can always treat that. If they have a risk there, you can pre-treat them. You can pre-treat them with Benadryl, but make sure they didn't take some sort of Tylenol preparation that had diphenhydramine in it. That would be a problem also. What else do we have here? The oral isn't so bad. If you look at the 72-hour regimen, there are several abstracts that we have here in this chapter that report it probably doesn't take that long. We clear it in about 20 hours, interestingly enough, from the oral route. So we probably can shorten that. And several of these abstracts talk about shortening it, 24, 48 hours or somewhere in between there. IV does not require ICU admission if the patient tolerates it, so don't think just because you're starting IV NAC, you've bought them an ICU bed. In Abstract 21, reported IV route is preferable. Abstract 22, the take-home message there was the mean duration of oral therapy, 31 hours, was just as effective as the 72-hour regimen. And 23, they said 20 to 48 hours. And 24, Abstract 24, talked about diluting this to make it more palatable. You know how bad N-acetylcysteine is when they say Fresca made it taste better. You know, I don't even think they make Fresca anymore. I had this once as a kid, and I thought it was the worst thing in the world. Do you guys ever have that? Yeah, this nasty stuff. So if you're adding Fresca to anything, you need to start giving it IV no matter what it is. All right, I think we're probably pretty close to time there. If you have any questions, I'd be happy to answer them, and Neil's on his way up.